Welcome to the AUA News Inside Track podcast. Today's Inside Track podcast is part of the AUA Census Trends series, which is brought to you by the AUA Data Committee. This series explores key insights from the AUA Census, highlighting how data informs workforce trends and broader patterns that shape the future of urology.
Welcome to the AUA News Inside Track. I'm one of your co-hosts today, Andrew Harris. I am the previous chair of the American Urological Association's Workforce Task Force. Very excited to be here today with Kate Kraft, who is the new chair of the Workforce Task Force, and to talk about a topic that is very important to both of us in our American Urological Association endeavors, which is how we understand data coming from the AUA Census. Before we get into that, Dr. Kraft, would you mind to just give us a little bit about you and your history and how you came to be the chair of the Workforce Task Force?
Absolutely. And Andrew, it's always a pleasure to work with you. I know we've known each other since our training, and it's great to continue working together on behalf of the AUA. So I'm Kate Kraft. I am currently Chief of Pediatric Urology at University of Michigan. So I've been in academic practice now for 14 years. I am very interested in graduate medical education and investing in the future of our field and preparing our residents and fellows for practice. So that's kind of the angle that I'm coming at. And that was a perspective that I offered when I applied to be on the Workforce Task Force. And just having been a part of that group for a while and really advocating for the future of our field, was very fortunate to be named the new chair, and I have big shoes to fill. Dr. Harris has done a great job, and I hope to continue to bear that torch. So thank you, Andrew, and it's great to be with you today.
Well, I appreciate those comments and your expertise in not only pediatric urology, but graduate medical education and residency training is so helpful to help us understand workforce and understand trends that may be happening that may be influenced by how we train. And so whether you're a practicing urologist, a resident planning your career path, or just curious about the profession, we're glad you're here. And what we want to talk about today is some of the census data that we have seen shift over time, particularly in solo practice. And so we have seen a change. About 12% of urologists were in solo practice in 2014, only about 7.5% in 2023. And so it's been a pretty decent shift in that practice model over that time period. And so I think what we would like to do is to talk a little bit about why we think that may happen. And from my perspective, I used to be in solo private practice in a rural town, and I really enjoyed the practice. However, there were parts of it that were quite difficult that may be influencing some of the shift that we see. And when I was in private practice, I was on call every day, and that became really challenging. And we use the term death by 1,000 cuts sometimes, and obviously it wasn't that significant, but it was just call all the time, and it made it really challenging to go out to dinner with my family, or to go on a trip, or to go to my kid's baseball game without getting called away. And over time, after about 5 years, that became challenging for me, and it made it hard to get a good night's sleep and hard to be refreshed going to work, and that was challenging. I think also with the data, we've seen a lot of metropolitan shift. And Dr. Kraft, I think maybe you can comment on this a little bit from the residency side, but we don't see as many people going to the rural areas anymore, where I think a lot of the more solo practices exist. And so as we have more shift toward metropolitan practice, we leave a lot of counties without urologists. And actually about 60% or a little more than that of our counties in the United States actually don't even have a urologist in town. And I think that's an interesting shift that goes along with solo practice. I think we've also seen a change in some of the practice models, right? And so I think, Dr. Kraft, if I could ask you a little bit, from your perspective, what factors do you see driving this change with those that you interact with every day?
Yeah, absolutely. And I think the stats are getting even more striking in the sense that the most recent census showed that now only 5.8% of practicing urologists are in solo practice. So the numbers keep going down. I certainly think it's multifactorial. From my lens in graduate medical education, what we are seeing in surgical training in general, not just in urology, but this has been shown over the last decade in all of surgical training, is that our trainees are really not feeling as ready for practice. There's just a lot more to learn in a finite period of time. The length of training hasn't really changed, but the amount of information and skill sets that our residents need to become at least proficient, and if not begin to master, has really increased exponentially. And so, what we're seeing is this feeling of lack of confidence, and there's certainly survey data to support that. But we're also seeing some objective data now measuring the performance and autonomy levels of our trainees as they're starting to transition into independent practice, and they're just not quite reaching those thresholds for being meaningfully independent. So that's a little alarming, I think, is a call to those involved in training, to our education system to really work harder on better preparing our trainees. As such, now as our trainees are transitioning to practice, they really want to be able to focus on lifelong learning and further skill development, which I think is important. We know that that's very meaningful and that mitigates burnout when you're able to continue to learn. But in doing that, you have to have mentors, right? You have to have partners who are experienced, who are willing to take new partners under their wing. And if you're in solo practice, that obviously is extremely challenging. Our residents are also really seeing primarily tertiary care referral centers. That is where the bulk of our training environments are located. And so our residents and fellows want to enter a practice that's akin to what they saw in training. If they are not exposed to more rural practices, then they may not think about that as an opportunity. I think there's a lot of benefits to being in rural practice and to serving our underserved communities, certainly. But if our residents aren't seeing that, then that can be quite problematic in terms of deciding on their future careers. This is an area that certainly the Accreditation Council for Graduate Medical Education, or everyone knows it as the ACGME, has recognized, and they're really pushing for not just in urology, but certainly in all fields to create rural tracks and support rural tracks and training so that our trainees are seeing more rural practice, and may think twice about the opportunities there to help serve our populations. As you said, the majority of counties, 61% per the last census, in the last several years of our census data, don't have a urologist. The majority of the US population does not have ready access to urologic care, which is really alarming. So, I think finally, another point is just having a community. We know that a lot of our group has focused a lot on burnout and the impact that that has on urologists and being able to have a healthy career for over a long period of time. But part of what mitigates burnout is having a support network and a strong community. And that's really challenging when you're in solo practice. So certainly if you don't have other partners to lean on, if you don't have others to share a call with, if you're, on call quite frequently and don't get to spend time on your own, personal goals and needs, and then if you don't have a strong relationship with maybe a tertiary or quaternary referral center, when things do get more complex, which is understandable, we've all seen that. So if you don't have that support network, and certainly, which is hard in solo practice, then burnout rates will rise, and then it's somewhat of a vicious cycle in the sense that our practicing urologists who may already be in solo practice want to exit and find other alternatives for practice. So yeah, I think there's a lot going on here, Andrew. A lot of opportunities to improve the situation.
I appreciate those points, Kate. And if you look at the AUA census data, most of our more rural urologists are also more advanced in their career and thinking about retirement. So a lot of those issues you just mentioned contribute to a more metropolitan shift because those practicing urologists are not being replaced as they retire, which will likely further exacerbate this in the issue. I think one thing I didn't realize and try to speak to residents about is not every place that you go are going to have the same access to care and the technology that we see in the academic or tertiary or quaternary centers. And And I think we forget that sometimes. You may not have a vascular surgeon readily available if something goes sideways in a big abdominal case. That might make you a little hesitant to do those, or you may not have an interventional radiologist on call if you need them, and that affects the way we practice a little bit. And as you mentioned, we don't train our residents that way, and that can be difficult when if they get into that environment to know how to handle. And so I appreciate those comments. Another thing I think is interesting, would appreciate your comments on, is training today seems a little bit different than it used to be, given how fast technology advances. And so, there used to be a handful of urological procedures that were done one or two ways. Now it seems that we have so many procedures we do that can all be done multiple ways. We have a case we're talking about next week. Do you want to do it open? We want to do a hand assist lap. We want to do a pure lap. We want to do a robotic. And that all means that they have to learn those things. And so I do wonder if that affects some of, what I want to be around people because I haven't done 2,500 TURPs when I finish training. And I want to be around people that can help me. And what thoughts might you have there?
Yeah, exactly. It kind of speaks to what I was saying earlier, Andrew, about just that readiness for practice component to this. We're fortunate to be in a field where technology is constantly changing, and there's always innovations and new cutting edge techniques for treating our patients. That's what draws many to urology, but it also makes for a challenging training environment in the sense that our residents have more they have to learn. And we all know that acquiring surgical skills and being able to safely care for a patient surgically takes time, and it takes a lot of investment. And there's only so much time that we have in training. It's 5 years for our residents to really acquire those skill sets. And then on top of that, when you have the faculty who are educating our trainees also trying to learn new technologies, they may not be allowing trainees to do quite as much, or that autonomy piece may not be as robust as we would want in training as faculty are learning themselves. So I think it's a challenge that's definitely, again, being recognized on a more national scale, not just in our field, but other procedural based specialties. One kind of, wouldn't say solution, but concept that's been promoted quite a bit is competency based medical education, which really focuses on the needs of the individual learner. So, for example, if a learner really nails how to do a complex ureteroscopy and they really don't need to spend more time on that procedure, then they can focus learning on perhaps another type of procedure, such as robotic prostatectomy. And so it really tailors the learning to the individual learner and their needs and their skill sets. And it doesn't have to be just in the procedural features of learning, too. There are other competencies like learning how to communicate with other team members, professionalism, medical knowledge, and expanding one's fund of knowledge over time. So I think that competency-based medical education is a concept that we're going to hear more about. It certainly hasn't been fully implemented in urology by any means, but discussions are taking place about what that might look like in our field. And in general surgery training, they're already implementing competency-based medical education concepts in their training as well as their board certification. So since our training models are so akin, both general surgery and urology, I think we'll see more of this, and it might be part of the solution for getting our trainees more ready for practice in that finite amount of time. I think another opportunity too is thinking about different tracks of training, and not everybody will be doing, for example, RPLNDs or really complex urethroplasties. And we need general urologists scattered all throughout the U.S. who can serve our patients, maybe who have less complexity, and those other more complex conditions or complex procedures could be reserved for again, the tertiary coronary centers. And so essentially creating tracks for one who really aims to go into solo practice or into rural practice or a general urology practice might be a consideration as well. There's certainly discussions on the national level about that possibility, but we probably won't see that come to fruition for quite some time. But I think we should continue the conversation for sure.
I appreciate those comments and discussing also not only about how do we get residents feeling more comfortable doing these procedures and providing access to patients. When we also look at those urologists that we're losing in those lawyers, there can be implications to access to care, right? Like if the residents don't feel comfortable being out on their own, we have a lot of work to do there. But then we have these older urologists who are leaving. What happens to those patients? And I think that's something that's very important. I know to us as providers, it's also very important to the American Urological Association. I know there are advocacy efforts towards trying to help these areas recruit and retain urologists. Would you mind to give us a little bit of your perspective? Because I know that the University of Michigan has a very large rural footprint around them. I know you and I have talked about this before. But what challenges do you see that the patients have when they don't have a close practitioner to?
Yeah. Yeah, we do see this. Michigan surprisingly is a fairly large state. We've got the Upper Peninsula where it can take families up to 8-10 hours to drive down to Ann Arbor to see us. And it's a very rural community there. I think I shared with, as a pediatric urologist, I'm one of few in the state, and I think I shared at a recent advocacy summit that I do routinely have patients who will travel from the UP, the Upper Peninsula, for hours to see me for the services that I can provide. It is a challenge. I think certainly one opportunity is leveraging telehealth more. I know that we as a workforce group have not specifically looked at just telehealth. There are others who are very invested in that facet of care and have done a lot of research in that space. But being able to ensure increased access for patients and their families with regard to having access to not just phone care, but certainly video care, making sure that there are robust internet systems in place, and just finding opportunities to support our patients in that way. Because not every, certainly in my practice, not every condition needs to be seen hands-on. I mean, a lot of what I see is image-based, and if you have a decent imaging center close by, then we can easily retrieve digital images for our own personal review, and help patients that way. So I think that's one opportunity that certainly we're already doing quite well in urology, but more opportunity for growth there.
Well, I appreciate those comments. Sounds like we have a lot of work going on to help serve these patients that we are privileged to have the opportunity to treat. Sounds like we have a lot of work to do in the future. A lot of bright minds working toward residency education, provider placement. How can we support them even at the federal or state level? And so really appreciate this conversation today. Appreciate all that you're doing for the Workforce Task Force and for the American Urological Association to help us understand these shifts and trends better, which will allow us in the future to advocate more for the patient. So I appreciate you being with us today. I appreciate the opportunity to talk with you as always, and just look forward to seeing what you're going to do with the Workforce Task Force. So thank you for serving in that capacity for the betterment of all of us and all of our patients.
Well, thank you, Andrew. And again, I have big shoes to fill, but it's always a pleasure to collaborate with you. And I think we have a fantastic team. It truly is a team effort. We're fortunate to have experts in all different facets of care, whether it's GME, APPs, rural practice. We've got it covered, and we can hope to continue to do great work so that we can serve our specialties, so that ultimately we can serve our patients. So thanks again.
We appreciate everybody listening. Thank you for joining us.
This has been AUA Census Trends, an AUA News and Sidetracked podcast brought to you by the AUA Data Committee. For more information about the AUA Census, visit auanet.org/takecensus.